This is Lab Medicine Rounds, a curated podcast for physicians, laboratory professionals, and students. I'm your host, Justin Kreuter, a transfusion medicine pathologist and assistant professor of laboratory medicine and pathology at Mayo Clinic. Today, we're rounding with assistant professor of laboratory medicine pathology from Mayo Clinic, Florida's campus, Dr. Komforti, to talk about navigating threshold diagnoses in the breast. Thanks for joining us today, Dr. Komforti.
Thank you for having me. It's wonderful to be here.
So I really appreciate being able to dive into this anatomic pathology topic, as I'm still anatomic board certified. So you're going to help keep me fresh today. But maybe for our more broad audience, why is this topic of navigating threshold diagnoses? Why is it an important one to talk about?
Sure. Great question. And really taking a step back and looking at the big picture, anatomic pathology, surgical pathology remains the gold standard of tissue diagnosis, and upon which really we build management for our patients, right? So, in very layman terms, if you think of a patient who presents with a breast mass, or on radiology, on screening mammogram, there's a mass. We don't know benign, malignant, or anything more than just there's a mass. So we have to get a biopsy, we have to get tissue, and it's on the pathologist to make that precise, accurate diagnosis to guide the clinical team.
Wow, so that really puts a nice fine point on today's conversation, right? I mean, you're talking about something that is benign, something that is malignant. I mean, these are two very different forks in the road, and highlighting that's your role as an anatomic pathologist. Uh, what makes a threshold diagnosis? And I assume when we say threshold diagnosis, we're saying something that goes from something that might be more benign to a malignancy. What makes that a challenge?
Yeah, absolutely. And I really would like to just, again, take a step back and sort of put things into perspective for the wide audience range that we have. It's important to know what even a threshold diagnosis is. It's somewhat of a newer term. You may hear in the literature borderline lesion in the breast. That's another way people have referred to this kind of diagnosis. So what are we really talking about here? So back to pathologist rendering an interpretation. It is an interpretation. So it is through the lens, through the prism of that individual. That's one element. The second element is that there are certain diagnoses in the breast that just have inherent diagnostic variability. And part of that is the fact that we have an imperfect tool, and that is the eye, right? So the eye can only see that far. We cannot see molecular alterations with just the naked eye. So some of those entities have overlapping morphology, they have overlapping immunophenotypical findings, they have overlapping molecular findings. And again, back to the eye not being able to quite discern between one entity and the other. And in general, when we look back over the past 50 years of breast care, we've really changed the way we manage our patients. In the 1990s, we were doing mastectomies for anything and everything. And now we've shifted to breast conservation surgeries, to sentinel lymph node biopsies rather than axillary lymph node dissection. Even trials at this time that are surveillance only trials for people with ductal carcinoma in situ of the breast. That means we're leaving this non-obligate precursor lesion inside the woman or the man's breast, and we're observing only. So things have shifted quite a lot, but it's really dependent back on us as pathologists to make that diagnosis, to help our clinical colleagues to know which route to go. So I mentioned a couple of entities here, and I'll just go back and review those. One of them was ductal carcinoma in situ, low-grade ductal carcinoma in situ. That is a threshold lesion, has overlapping features with atypical ductal hyperplasia. Some of us in the pathology world, my colleagues know, we refer to those as ADH and DCIS. And our criteria for those two lesions, how to discern them adequately and accurately, that criteria was developed in 1982 and later on with an update in 1990. And now it's 2025. So what we used to do before, 50 years ago, 40 years ago doesn't quite give us enough information in the era that we are currently, which is the era of de-escalation of treatment for breast cancer patients. So how does that again relate to threshold lesions? Why is that important? Because we are increasingly asked to give more and more details, to continue substratifying into more and more diagnostic buckets all these lesions and providing more detail to our clinicians so they can pick the correct route of treatment. And I'll just stop there and give you an opportunity because I realize I covered a lot of different topics in a very short amount of time. So I'm ready for a question if you have one.
Yeah, yeah, no, I really appreciate how you took us through there. And we're talking about the example of ductal carcinoma in
Mhm.
situ and the very closely similar but different diagnosis of atypical ductal hyperplasia, so that DCAS ADH sort of dilemma. And I think if I'm thinking about our student listeners out there, kind of appreciating the fact that this kind of highlights the reason why a pathologist is somebody that has to be a physician to understand what is the clinical significance of what a particular
Absolutely.
call is, as well
Mhm.
as your specialized skills as a pathologist. Is that something that when you were training, you were really kind of cognizant of, kind of connecting your medical background and
Mhm.
your pathology specific training?
Right, great question. Extremely important to know what your diagnosis means to the patient, to the clinician. I would say for our students, our residents, just starting in pathology, get the basics down first. Get to understand those ideal images of what ADH looks like, of what DCS looks like, what invasive carcinoma. Get to know that, build that brain bank of images, and then be prepared that depending on the practice you go to, where you are, you may have a substantial number of those threshold lesions, perhaps even up to 15%. So a fraction of what you're going to see will fall into that, oh my God, I'm not quite sure, is it ADH or is it DCIS? So I think, of course, know the good examples because we always compare abnormal to normal. So you have to know in your mind what abnormal looks like to make that determination. And that's how I approach my career. That's how I approach my training. And then it was that extra layer of learning. And I would say that learning never really stops. It continues. It's a lifelong learning journey of what it means to make the diagnosis and how to fine tune and how to find that sweet spot of feeling comfortable with uncertainty. And that's what really threshold lesions are. They're uncertainty. And you, as a breast pathologist, have to find that comfort level.
I really appreciate you use that phrase, is kind of navigating uncertainty. That's something that I've hear discussed in many kind of contexts of medical care. If we kind of putting on imagining now, not necessarily a student, but somebody who's maybe young in their career, uh, and listen to this podcast, what are your thoughts on, recommendations for how do we navigate
Mhm.
these threshold diagnoses, right? You're
Yeah.
you're confronted with a case that's, is this DCIS, is this ADH, as you've been talking about? How how might one start to navigate that well?
Right, great question. I think again back to what we just said is cover the basics, right? Cover the basics because if you don't cover them and you show this to your colleagues, they will ask you, do the basics. What are the basics? The basics are let's stain it. That is an easy thing to do. Common stains that almost every lab has. We certainly have them here in Mayo and all of our campuses. Get that CK5, keratin 5, get that estrogen receptor stain and see what the lesion is staining like. Of course, there are other things you can try, levels. We like to think of lesions as 2D, but in reality, they're 3D. It's a formalin fixed paraffin embedded block that is approximately 4 or 5 millimeters. So there's definitely that Z plane, right? Let's see how the tissue, how the lesion develops. Is it going to open up? Is it going to get smaller? Did we pretty much excise it with the biopsy, or there's more that we're not seeing? So get those levels, get that basic workup. That's the number one. people say, my more senior colleagues will say, I want to sleep on it, right? So just think of the next day, look at those things, and come back with fresh eyes. And I like to also say it's most important to get the diagnosis accurate rather than to rush it. So let your clinical colleagues know that there may be a little bit of a delay on the case because we're working it up. That is perfectly appropriate. So that's the basics. Now, what else can you do to help yourself? And there are a few things you can do to help yourself. Number one, don't be a hero. Don't commit to a diagnosis that is not quite applicable to this patient. So if you need to have a descriptive diagnosis on your final diagnosis, then utilize that. What are some examples? We keep talking about ADH and low-grade DCS. We know there's going to be a subset of those that will define accurate reproducible classification. So when you're faced with one of those, because it's a matter of when, not if, when you're faced with one of those, use a descriptive diagnosis. For example, atypical intraductal epithelial proliferation, C comment, or at least atypical ductal hyperplasia, or atypical ductal hyperplasia bordering ductal carcinoma in situ. Let your colleagues know that this is not your straightforward lesion. And that is a way to help yourself, because we don't want to overcommit and we don't want to be too brave with our diagnosis, because you can imagine the significance of carrying a diagnosis of cancer. That comes with a lot of repercussions, right? A lot of anxiety for the patient. There's a lot of treatment that's involved, and so on and so forth. So you're helping yourself, you're helping the patient, you're helping your clinical colleagues by admitting the challenges of the lesion.
I'm if I could interject for a quick second
Sure.
and just say, I this conversation is reminding me about why I went into pathology in the first place, right? I love it's an honest medicine, right? Where you're saying like you're not being the hero of kind of flat-footed calling something, but you take I guess, would you say like you take the histology to the limits? Like what you were able to call, you call, but you're careful to not go further
That's
uh,
right.
than
That's
what
right. And
you
we
have
have
in front of
to
you.
we have to practice safe medicine first and foremost, right? And of course, it's up to the patient what kind of treatment they'll elect at the end, but I have to be able to sleep at night to know that I've done the best I can. And sometimes that means, in this day and age, we mentioned de-escalation of therapy. We've removed ourselves from being too aggressive in surgery, in oncology, in radiation treatment, and so in pathology as well. What we used to, by the Page criteria that we mentioned, 1982 or so, 1985, around that time, that criteria tells us that as long as we have 2 millimeters to 2 duct involvement by these low-grade neoplastic proliferation of cell, then we feel comfortable calling it DCS. In reality, I will tell you, myself included, my senior colleagues in pathology, we actually allow for more. We're pushing that border, we're moving that bar. We allow for 3 millimeters, maybe 4 millimeters. We like to quote, see more. And there's not really a good definition of what more looks like, but we are pushing that bar. We're being safer. We are noticing that with all the advancement that's happened in the past, again, 40-50 years in breast medicine, breast cancer mortality increases. So we've been excellent in catching smaller and smaller lesions. We're talking about a couple millimeters. Our radiology colleagues are phenomenal. They catch small calcifications, small lesions. We excise them, we treat the patient, and yet there's no really effect on mortality from invasive breast cancer. And that's really what we're trying to do. We're trying to prevent breast cancer by treating ADH, atypical ductal hyperplasia, and low-grade DCS, ductal carcinoma in situ, the non-obligate precursor, right? So maybe we're over-treating, or maybe we're over-diagnosing these lesions and being a little too aggressive. So back to, don't be a hero. You're doing service to yourself and the patient by being careful and admitting challenges. And that, I would also go on a little bit of a side note here and mention, when you admit challenges, when you have a comment that explains, hey, this is an in-between lesion, this is a borderline, a threshold lesion, you prevent the misconception that another pathologist is wrong. Because oftentimes what patients do, and they're extremely smart, they will go to another institution, they will seek a second opinion. And depending on how the other pathologist is trained, remember, going back to this is just an interpretation, depends on the person interpreting it, right? The pathologist. Depending how that person is trained and their personal approach and understanding of the literature, they may be just a little more aggressive. And then two different diagnoses may happen. And then the patients may think, well, our one pathologist is wrong. Which one is it? These are two separate lesions. And there's a lot more understanding than that we don't convey, that these are related lesions from the low-grade neoplasia pathway and that they're threshold lesions, right? So by being careful and not being a hero, you're helping your colleagues and prevent the misconception of somebody, a pathologist, being wrong.
I really appreciate that, and I think it underscores for the clinician listeners to this podcast, right? If you see a pathologist that's using a descriptive diagnosis, maybe they're using a diagnosis that you're unfamiliar with, or like Dr. Conforti mentioned, uh, basically using C comment in the diagnosis field. I think it's highlighting that definitely see the comment, and also don't hesitate to reach out with a phone call.
Yeah, that's right. When we write these reports, we write them for a wide audience. So obviously the patient, obviously the surgeon, radiologist, but there's billing, there's research, there's the other pathologist who, again, if the case goes out, the material is sent to another institution. There's the trainee. I talk to myself sometimes. I use certain terminology and certain sentences. So in a situation where I get a phone call, anybody asking about my report, I can tell you exactly what I saw because I understand what my words mean to me. So we speak to a wide range of people, the nurses or the techs who code these lesions, right? They have to have a drop-down menu, they have to code everything. It's very complicated. So every so often things will be conveyed in a way that's perhaps suboptimal because it's not a diagnostic bucket, and we like buckets because they follow an algorithm, a treatment algorithm. But we also have to admit that breast pathology has those threshold diagnoses and lesions, and it's just by playing the numbers, eventually you'll be faced with one of them.
Kind of, and I appreciate you've taken us through a little bit of, how to work through this, through these challenges. Kind of putting on my looking into the future hat. What do you think? I mean, is this something that, I think you mentioned, right? It's been several decades since the criteria was previously revised. I mean, is this example that you've mentioned today, this ductal carcinoma in situ versus atypical ductal hyperplasia, is this threshold diagnosis just going to continue to be a diagnostic challenge, or are there's going to be new technologies or new ways that we may separate these more reliably, and maybe there will be different challenges going forward in the future? Uh, what do you see on your kind of future prognosticating for how this is going to look?
Sure. Yeah, I think it's very exciting. Some of my colleagues who are listening, or for the students and residents who are thinking breast pathology, they may be discouraged because they're thinking, oh my God, this is so hard. And it is hard, but it's exciting because there's so much more work to be done, so much more to be discovered. It's truly, we don't know, right? And you could be the next person who cures cancer. I don't know. But I do think there is going to be a shift. And I think part of that is AI. We've seen AI help us on many different things and fronts, in breast pathology included. In Mayo Clinic, Florida, we do automated interpretation with AI for some of the biomarkers in breast cancer, for example, proliferation index, MIB. In Rochester, they do estrogen receptor, progesterone receptor, HER2. So it's extremely helpful because it provides that precision. It is not a subjective, it is an objective tool. It's reproducible and it provides precision. So there's going to be, I think there's going to be an improvement in the way we render diagnosis just by incorporating some of those AI tools. But I also think that there has to be an added layer, perhaps incorporating molecular into our diagnosis and not just immunophenotypic findings in morphology. I think there has to be an added layer. And I know there are a couple of companies out there working on that. And hopefully in a couple of years, if we do this again, I may have some more information for you that we can share. But as of right now, work in progress.
Right on. We'll definitely be bringing you back. One final question I have for you, since you brought up, and we're talking about AI. As a pathologist, what do you think? I think there's this. I work a lot with the medical school,
Mhm.
and I think that pathology is one of these careers that I think there's a perception among medical students of, in the world of AI, what is a pathologist going to do? What are your thoughts as an anatomic pathologist and AI? Your answer there you highlighted was really talking about it kind of almost behaving as an adjunct of kind of integrating additional information, and then you as the pathologist overseeing that. But what do you think that future interface is going to look like?
Right. This is a tale as old as time.
Mm.
So I've been told by my senior colleagues that when immunohistochemistry came out, pathologists were like, "Oh my God, this is threatening our jobs." And then molecular came out, and pathologists were like, "Oh my God, it's threatening our jobs." So it's. In other words, this will be the solution to our problems, and it was not. And I kind of hear a little bit of that with AI, where AI is out and it's going to solve all of our problems, and pathologists will be out of jobs, right? Something that people forget is that it is the breast pathologist, and because we're talking about breast pathology, it's the breast pathologist who teaches the AI. So who builds the ground truth for the AI? It is that pathologist. And I've had a couple of projects where we sit down and we annotate and we teach the algorithm what cancer looks like, what benign looks like. So there has to be a human element. There has to be a human element. And I think we need a lot of perspective data before we can remove the human element. Until then, I think we'll be okay.
I totally agree with you, and I see that role, and I think, it's gonna. My own thought on this is right. You're highlighting this ability that it's going to enable you to focus on even other things, maybe. And as you pointed out in the specific case of breast cancer, maybe what you are able to focus on going forward is going to be something that moves the needle as far as what does the mortality look like for men and women who suffer from breast cancer.
That's right. And there's a lot to do in pathology. And I urge you to explore it as students or residents interested in that specialty. It's not just sitting in your office looking at slides all day. It's very exciting. There's a lot of, like we mentioned, AI, there's education, there's research, trials, innovation. It is just a very exciting time.
We've been rounding with Dr. Conforti, talking about navigating threshold diagnoses of the breast. I really appreciate you joining us today.
Thank you. My pleasure.
And to our listeners, thank you for joining us today. We invite you to share your thoughts and suggestions via email to mcleducation@mayo.edu. If you've enjoyed this podcast, please subscribe. And until our next rounds together, we encourage you to continue to connect lab medicine and the clinical practice through educational conversations.